Good afternoon, everyone. I am very much thankful to MPSOS and AIOS APU for giving me this opportunity. So today I am speaking on systemic considerations in cataract management. So whenever there are systemic comorbidities, it adds up to the investigations preoperatively so that we can get a fitness for the surgery. Now, we need to sometimes change our surgical approach to minimize the intraoperative complications and do preoperative investigations, and many times there are post-op precautions also that need to be taken. So diabetes has already been taken in depth with by Dr. Alok Sen, and I am not going into the management of diabetic retinopathy in diabetes, but since one point of line I would like to add is how diabetes impact our cataract surgery. There are biometry challenges, there is delayed healing, there is increased risk of infection, and there are chances of progression of diabetic retinopathy. Now, for diabetes, the fasting blood sugar needs to be kept below 140 and postprandial less than 200. And we all know that OCT is a must in patients with diabetes. Now, coming to a patient having hypertension, in the patients who are having high blood pressure, the BP needs to be controlled. Many times intraoperatively there are sudden BP spikes and fluctuations which can increase the chance of choroidal hemorrhage, expulsive hemorrhage, vitreous loss, and this can lead to poor visual prognosis. And also many times there are increased chances of posterior capsular rupture. Also there is endothelium is in stress and there can be corneal edema. So the BP must be kept less than 160 by 190 mmHg, and many times we have to keep anesthetist standby, and they can give labetalol in the doses of 10 to 20 milligram IV over 2 minutes, and if needed that can be repeated after 10 minutes until the BP is controlled. So BP should be well controlled before the surgery. Now let's take a case of a patient who is on anticoagulants or has a low platelet count. So we usually are not stopping anticoagulants before the surgery, but the patients who are on two anticoagulants like the aspirin and clopidogrel, so for them aspirin can go on and we need to withhold clopidogrel, and we also need to see and weigh the thrombotic versus bleeding risk and stratify the patients whether they are high risk patients or at low risk patients. These are the conditions given by the American College of Chest Physicians, and these are high risk patients, and these must be taken with the anesthetist and after cardiology fitness. Now a patient who is on tamsulosin is a high risk for floppy iris syndrome, and the surgery must be done with the great care. The parameters must be kept to low, the bottle height should be low, the fluctuations in the NTH chamber needs to be kept to the minimal, and if needed we can use pupil expanders, and you can see this pupil is small, and still the surgery can be managed if we keep the parameters to low. Now a patient who is having Parkinsonism or dementia, they can't keep still for long times, and they usually have tremors which can affect the eye stability. So these patients can be kept under short sedation, and we can avoid topical anesthesia in these patients, and anesthetist standby is a must for these patients. And if needed, we can put a suture on the incision, and we must see for the post-operative compliance for the patient. So now RA patient who are on long-term steroids, and these patients also have associated dry eye. So what preoperative considerations we need to take into care is that these patients usually have ocular surface disease, the dry eye, episcleritis, scleritis, and they are at risk for poor wound healing, and also there are chances of cystoid macular edema. So we usually prefer doing it under topical anesthesia and a clear corneal incision. We'd avoid giving a scleral incision. SICS is a big no for RA patients, and optimize the dry eye with lubricants preoperatively. And since they can have neck rigidity also, you can use intraoperative adjustable headrest, tilt the microscope for comfortable positioning, and post-operatively we need to avoid prolonged steroid use because they are at risk for glaucoma and delayed wound healing. Now a patient with kyphosis is a big problem when we are operating him. SICS can be done very easily by managing the position of the patient, but when you are planning the patient phaco, a reverse Chandler position is a good option. And Dr. O.P. Agarwal sir is a big expert in operating kyphosis patient, and we are all aware with the videos he has many times shown us. So these are the various positions that we can make and do comfortably the operative procedure. Now, a patient who is seropositive with HIV and is on ART with mature cataract, in those patients, a preoperative CD4 count is must, and these patients are at risk for opportunistic infections, and a clearance by the physician is must, because many times we need to give post-operative steroids also. Also, these patients have bleeding tendency because of ART-induced thrombocytopenia, and this must be kept into mind. Along with that, standard universal precautions should be followed, and these cases must be kept for the last case of the day, and instrument sterilization should be done properly at the end of surgery. Similarly, for HCV patients, these are at bleeding risk, and there are high chances of intraoperative and postoperative inflammation. So PT-INR count, liver function test, and viral load preoperatively must be checked. Now, case with the Alport syndrome, this is the case of a 12-year-old child who is having a renal failure, and on examination, the child had a lenticonus. So these patients, because of lenticonus, are usually amblyopic, and amblyopia management must be done at the after the surgery. And during surgery, we can go for a PPC with vitrectomy. To conclude, systemic comorbidity impact cataract surgery outcomes significantly, and a multidisciplinary collaboration with the physician and cardiologist is a key. And preoperative optimization can reduce the intraoperative and postoperative complications. Thank you.
Thank you, Professor Shweta, for the very informative talk. Thank you so much.